want to really focus on solutions and stuff, because I know that you probably have lots of talks about balance, about falls, and so how can we transform these topics more practical for people, I think is very important, is a new challenge. I will start just by placing the problem in terms of its relevance, right? If we see that falling in Parkinson is particularly worrisome, we do talk a lot about it because this is ultimately something that we're concerned about, because when we compare it to other neurologic diseases, it really stands out. And I think what stands out is also is the impact it has on both the person with Parkinson that's falling and also the care partner. And this was a quote that someone that I treat said, that my wife finds it difficult to believe that I just can't stop falling. So the falling becomes so frequent that it's almost like the person with Parkinson will consider it normal, as if it's become part of your life. So it's okay. I fall, I get up, no major issue. So we start this risk of a certain disvaluing the problem, right? And there's no need for us to go, I understand because of the frequency this will happen, but we do have solutions. And so I think it's worth reflecting on those solutions and finding a different way. I would like to highlight that from the perspective of the care partner, it's often that the person with Parkinson might not understand the anxiety that it creates. And so care partners might become a little bit more protective. And like, he wants to go out to go drink coffee, but I stay at home in a panic attack thinking he's going to fall, right? So this coming from a perspective of a care partner, living the moment and the anxiety of the person might fall at any time. So I think it's important for both to understand how one wants freedom, wants autonomy, and the other one wants to keep you safe as well. And from that perspective, when we think about solutions, it has to serve both purposes, right? So I'm going to dive into what I would, when I have someone that comes in and is dealing with falls, how do I organize how we treat, and how do I guide people in the strategies for them to stop or reduce at least the falling. The first step that I usually would focus on is helping the person really understand what are the reasons why the person's falling. It sounds maybe vague question, but there's so much that can come behind this, which is what is the situation? In what situation did the fall happen? In what place? What activity? What was the person doing? What did the person have in their hands? So this type of information is so important for us to be able to guide into the right direction. Once we know what is the cause, what is causing, or I would say the factors that are most contributing to the falls, then we can actually stop to think about, okay, so what can I do about the person? So me as someone that's falling, what can I do to change my behavior as someone living with it and falling? What can I do about the activity itself, what I was doing, and how can I change what I was doing? Or maybe I can change something in the environment. And so as you can see, like, one has to automatically exist to lead to the other. Find out what the problem is, and then focus on how can we change either the person, the activity, or the environment. And I will give you lots of examples throughout this session on how we can use this guide. There is something laterally that should happen always. So imagine if I only have one session with someone and I'm not going to see the person anymore, at least the rescue strategies, what I call, is learning how to get out of the floor, which sometimes we tend to only train after or later in rehab. But I think it's fundamental for people to get these type of strategies immediately. So learning what should I do every time there's a fall? How do I know if I should always be calling 911 or should I just help the person get up, right? How can we distinguish that? Giving people that knowledge is fundamental. Now, this slide scares me personally, and I can imagine it scares you. When I'm saying, okay, so the first thing is find out what the cause is, right? Find out what the problem is. And then guess what? This is the list of all the problems, all the risk factors that can actually be involved in Parkinson in falls. Sometimes we have more than one that is contributing, and that's why we must make sense of this knowledge. And even more important is to be able to really pinpoint which one is the one that's contributing more to that person's fall, right? Because if we start talking about general things, take out all the rugs, all those things that, you hear a lot about reducing falls, and then it might not be specific to why you are falling. So it might not make sense. I actually created, so according to what is studied, you have these two columns. So general things like old age, having arthritis, anxiety, you can see the list. I won't go into detail. Then you have very specific things regarding Parkinson. So all those symptoms, the rigidity of the trunk, you have the cognitive difficulties, the history of falling is usually one of the most important ones. If I've had a fall in the last 6 months is one way for therapists to see if you're at risk. And the list goes on. And then I actually created another one. Wait a minute, there's other things that are happening in Parkinson, which we are now finding out that might also be contributing to falls. And I will also give you some examples on that. Okay, so I'm going to run away from this awful slide to really bring this key message to you. In order for us to help you reduce the falls that you are having, we have to be able to identify which are the factors that are contributing most to your falls. That's the only way any health professional, any help can help you. And so how can we get there? If the list is so big, how can I get help? And when we think about, obviously, you'll always be guided to, if you are able to have access to a health professional that can make this assessment. You are not supposed to know that table, right? Even they don't know it, right? We have to also look and study these things. And when I'm starting to have problems with the fall, there's certain key things that I probably want to think about when I go and talk to someone. So if I'm going in for consultation and I'm reporting it to the doctor, the way I'm reporting will inform him about how he can help you better. So there's a responsibility of gaining that knowledge, and that's why we have talks like this, so that we can help you in how you report your problems as well. And so that means I come in and I say, you know what, I started falling now. So it's something that's new. It's a new problem. So since the last consultation, this is something that's new. And it's impacting me like I'm falling always in the morning. So it's like giving a notion to the doctor that this really impacts you so that he can really manage it. Because I can imagine that the list is so big, usually when people are it's a complex disease. We know that people have lots of complaints. And so, and the doctor might be focusing on things that he might change with the medication, and unfortunately the medication is not so effective for issues like balance and falls. Again, depending on the cause, and I will give you examples on that. So these are just key messages like potential causes, thinking about what is making me have these falls, and one good way for you to be able to take valid information that will help either if it's a therapist or if it's a doctor, is to have a nice falls diary. And I'm not sure, I think we are sharing the slides with you, but anyway, you'll have the talk. So this is a tool that I like to give to the people that I work with, which is, could you please monitor, what is the time of the day where your falls are happening? Is it after your medication? So when you fall, do you think that your medication is having an effect? This is very important so we can see the relationship to the medication. And then if you can tell me where you fall, I can see more or less why that is happening. If it's in the toilet, if it's during the night, completely different intervention I'm going to have. Another one is, what were you trying to do? Because we know that the intention, I'm getting out of the couch, I can do this safely, but in that moment, the doorbell rang and I suddenly was under a certain amount of anxiety because I was expecting my grandkids, and I tripped and fell. Or sometimes the tripping is irrelevant. So it's like what the person was doing so that we know that it's the interference that happened that was the cause. In what direction you fall will help us see the impact that the falls might be having. If you are telling me that you are falling backwards, we have to urgently get you equipment to protect you, namely the head, right? Most common falls in Parkinson will be more forward or sideways, but it's just so that you know that the severity will be and the way professionals will react according to the information that you give them. And then injuries. People have several injuries and they usually tell me like this, I don't know why I don't break more things. And I usually say, you know what? The rigidity is probably protecting you. It's a false protection, but it's there. And it's true. So people do endure a lot of injuries. And it's almost getting used to it seems really negative, but it does happen. And then your perception, because sometimes people will tell me, I don't know why I fell. I was just walking forward and suddenly I fall. And just by using the sentence, I understand that probably the feet got glued to the floor and the person didn't perceive that that happened and fell. Okay? So it leads me to interventions that are regarding what we call freezing of gait. Okay, so, and then the other one, obviously, how do you get up from the floor will also be an urgent notion to see if you have help or not at home. Involving always the care partner or whoever you live with and family and friends, because they will always have a different perception. They see the problem in a different way. Okay, so hopefully you can take this tool from, and if I had to finish my talk here, I hope this at least is one tool that you can use to be able to report better and to understand your falls better. Everything good? Yes? I have some videos, thank you. It's nice when we see faces because then we're talking to people, so thank you. And now how about we use some examples of this, right? So I really wanted to bring this, to make the presentation as practical as possible, being such a complex topic. So I'm going to choose from that table, that tremendously awful table, I'm going to choose just one or two things that we place there as full risks. And so that you can see that if I'm dealing with that, what kind of solution should I be aiming for? So how about this one? So I had, this is someone I work with. Her name is Amalia, and she is quite young, and she tells me, I fell in the street. I felt like my feet got stuck to the floor. It seemed like I couldn't walk, and instead of stopping, I insisted and fell forward. This had never happened before. And it was interesting because we go through the whole interview, and if you are interested, it's actually on YouTube because I go through the whole thing with her, and it's basically understanding when did that happen, and we, in all the triage questions that I asked her, we realized that she actually went in the afternoon, in a time right after eating, and in a time where her medication wasn't working so well. So again, this is a surprise to her because it's the first time it's happened. She would not expect it. And what we identified is like, yeah, you usually take your walks in the morning, and on that day you decided to do it in the afternoon. There was a change in habits, there's a change in medication, probably depending on what you ate. Now she's Portuguese, so we do have like an hour for lunch. We sit down and we have meat and chips and rice and stuff, so that it's really heavy meals in the lunch. So we know how that might also influence how the medication is working. So just by alerting her to this, we reduce the panic. It's like, you know what? The most probable cause was this. And she said, I never thought about that. So don't worry. Just be sure that when you decide to take a walk, keep in mind if your medication is working well or not. And I think it's important for us. Knowledge will help you not create anxiety and have better control over the disease. I think knowledge is very important. These type of talks, I think, hopefully they're really helpful. Let me give you another example. So imagine, let's take someone that has his dinner at around 5. This is an American. So you usually have dinner at 5 and 7. We usually have dinner at 9 and 10, right? So the difference is that let's just go through the cycle so we understand. So this person, he seems to be complaining about when he wakes up, he has falls. And we must try to understand, wait a minute, what's happening in the morning, right? So that you understand this morning means that he has spent the whole night without the medication. Even if he took his last dosage at 5 or at 7 o'clock at night, his next one will only be, imagine, around 9 o'clock. Which means that when the person wakes up, and this will be when people ask about progression of the disease, this is something that we know will happen in terms of the medication might not be working so well, and so you have more difficulties. And this will most commonly happen in the morning when you wake up because of this scenario, because you have been without the medication through the night. which places you at greater risk for what? For having shorter steps, for shuffling gait, so the person struggles more to get to the toilet. And in these situations, sometimes you're not expecting it, and again, it happens. And how do you think that we could solve this problem? This is where I would love to hear your voices, but since we are many, I can't get that. But I just wanted to share with you, reflect on this. How do we solve this? Would we go do exercise? Would exercise make any sense here? Would strategies make any sense here? So using like strategies for us to have bigger steps, it could help, that's true, but we must be objective. The
Give them that.
cause of the fall is the medication not being active at that time, right? You'll all agree with this, which
Yes.
means when we think about our strategy, what can I do about the person? What can I do about the activity? What can I do about the environment? When I go back to this, what I can do about the activity is probably change several options. If you contact, I don't know the autonomy in America, but usually I would say contact your doctor so that he can adjust the medication. And the doctor will probably do something like this. He will either give you medication later in the evening before you go to bed. He might give you medication that is a prolonged effect. He might suggest, I would suggest as a physiotherapist, why don't you take your medication still in bed
Mhm.
and then wait for the effect. It doesn't change anything. The doctor's not going to be mad because you made that change. It's an effective strategy. And so that means that when you are getting out of bed, the medication is already working and you're not placing yourself at risk. So just to highlight, we have falls because someone wakes up in the morning and the medication is not making the effect. We change the medication, the person stops falling. The falls are solved. So it's solvable. Once we find the right culprit, we can act on it in the right way. Now imagine the person tells me, you know what, I'm falling is during the night. We have a similar situation, right? During the night, the person usually wakes up, especially if you're dealing with sleep issues, that's quite challenging. I have a gentleman that says, I always have to wake up at 3 o'clock in the morning. I go to the fridge and I eat a yogurt and then I can go back to sleep. That's his strategy to going back to sleep, right? But the truth is there is a risk of having more rigidity, more slowness, more gait problems during the night because of if your medication is not if you're not taking medication for that timing. So in this case, if the person says I'm running the risk of falling during the night, what am I going to think about? Well, I can't like give medication all the time, right? I'm sure the doctor we can think about contacting the doctor. He might change something before the person for the night, right? Medication for the night. But we also have to think about good sense strategies, which means is there something that I can do about the environment, right? Is there so that I can reduce maybe the need of going so many times to the toilet, or so we can think about, let me see, strategies which we could reduce the risk. And this is the most common ones that you hear about having good lights. I particularly like this one that as soon as the person puts the feet on the floor, light goes on. And so because sometimes if you have a sensor one, like you have here on the right, I don't know if they're all like that, but only when you pass through it or very close to it will it go on. And that's a limitation, right? Because there's a moments when you're going to be in the dark. So just finding ways during the night, how can I reduce the fall? Maybe I can have an adapted toilet that is closer to me. How far is your bathroom? That's important to study as well when we think about changes in the environment. And even I treat a lot of people that are also young onset, and sometimes these changes are challenging because the person's so young. But because adapted equipment is challenging to change. But the truth is, it brings a lot of quality of life. And so people, once they try it, it really helps. John, you have something?
Just a couple people in the chat have brought up that they've changed to a controlled release formulation,
Mhm.
whether that's a CR or that's one of the ones like Oh,
Mhm.
what's the long acting formulations, and some of that can be valuable, and also the doctor could also work on a medication formulation that may also have sleep as one of its side effects in a way to hack it. And those are totally appropriate. This is why you talk to your doctor first, because it might be an option. But these are ways to go beyond that, or ways to work with your physio. Is that correct?
Yes, yes. And believe me, if the doctor solves the problem with this, forget all the rest. I mean,
Yeah,
obviously
yeah.
we can prevent future things, but you've got so many strategies that so many therapists are telling you that you have to put this into a balance. What am I able to do if every single multidisciplinary team member tells me to do something?
Yeah, it could get overwhelming. If your doctor gives you Rytari and it takes care of it overnight, then, God bless and move on.
Yeah. As long as you're doing what everyone recommends, which is a healthy diet, healthy exercise, blah, 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 you're doing your role, right? Okay, so let me just go into more examples. So that was one. Now, one that maybe we wouldn't think about so much. This was an interesting situation that happened. This is based on my clinical experience. So I had a gentleman that I hadn't seen for a while, and then suddenly comes in and says, the constant falling now is a problem. This weekend, we could barely move. Today, I'm better. And then was it, can you identify? So my first question is like, why the sudden change? Because we weren't having this issue. Why is he suddenly falling, right? And then the person would go on, I feel more difficulty in walking and a lot of trouble with constipation. And because he had never complained about constipation, I was like, okay, you know what? Tell me more about this constipation. What's going on? I had been out of the country, so it's been 9 days without going to the toilet. I just went yesterday. So you can see in the like, today I'm feeling better. Yesterday I went to the toilet, which means that we do know the research now, we have already showing how that the treatment of constipation, so being the dosage of the medication that has to be absorbed in the intestine, right, is compromised. So that means it's almost as if the medication is not making effect. And so you will have a less clinical response to the medication you're taking, levodopa specifically. So these I would say, this is not on the list, but now it is, right? So there's always new knowledge coming in, and it's important for people to identify. So did we be worried about that? We have to think about solutions about constipation. So in this case, we identified the factor, the cause that was provoking these falls. It was constipation. The next step is like, okay, so how are you managing this problem? And then we go into the non-pharmacological strategies that you can use for constipation, right? To give you more examples, I'm going to jump to another one. So how about excessive fatigue? These were all very atypical fall risks that we don't hear so much about. Let me just put the video. The gentleman is talking Portuguese. Let me see. I'll lower the sound. And he's basically this was several videos that we did about regarding falls for a project that I did here in Portugal. And it's basically telling he got so tired, he was so exhausted getting out of the car that he fell. Okay, so I identified, okay, you're taking too long to get out of the car. Let me see if you are able to using certain strategies that I'll teach you, if it is possible for you to get quicker. And you could see by the timer that it was possible. Just teaching him how he could just place his hand on a certain part of the car, and how that improved, like I think it was less than half of the time that it took to get up. And these getting up quickly, obviously, is you bring orthostatic problems as well. But this one is the fatigue and not breathing. Usually, it's like his wife would complain a lot. It looks like he's not breathing during the activity. So the effort is so much that he actually holds his breath in. So when he gets up, he falls. Can we identify strategies for this as well? There's lots of pharmacological interventions and non-pharmacological. So that's everything else with a multidisciplinary team that can give you tips and tricks for how can I deal with fatigue, for example. And I was just laying this out so that you can at least have the positive message that it's treatable as well. We can think about maybe the time that the person's getting out of the car, right? We can think about these strategies like I used, that's changing the activity. We can think about where he places his car. There's things we can do. let's grab onto another one. So axial rigidity is about how it's one of the hallmarks of disease, which is of Parkinson's disease, which is the rigidity you might feel in the trunk, and which means that things like getting out of a chair and things like getting out of bed becomes tremendously difficult. And so it places you at risk. And let me give you another example here. It's very difficult for us to have obviously videos of falling, as you can imagine. This is a gentleman, he's just showing me how he fell, and he almost fell, showing me how he fell, right? So it's really the way he's placed his table when people are coming in. So I would come in from where he's turning now, which is interesting. If I told him, why don't you sit on the other side, so you're not reacting to whoever comes into the room. Another strategy would be to, how are you doing the movement? So if we can push more space between the other chairs, placing your foot. So teaching him what we call cognitive strategies. And then because I know he's going to be very distracted, I put some lines on the floor. As you can see, those green arrows. I would usually put like red, but I had to put green because he was very sensitive to how the floor looked. So it's important to also have that into account. Sometimes we want to propose things that are not so accepted, but it should have a contrast so that he would, the arrows simply allow him to remember that he has to really think about the foot that's coming out. Okay. And then this is him. Then what we do is like, can you show me the position in which you fell? And then we would train that. How can you get out of this position? So what I just did there is thinking about if specifically the person is, he would like to stay working until late and the wife would go to bed. So just timing of, that's his habits, that's his personal habits. It places him at greater risk because his support is obviously sleeping. Can I convince the person to change his habits? I can be pretty convincing as a therapist, but the truth is it really depends on the person, right? The person has to want to change. And we try, we give our arguments, but it really has to be from the person, those changes. That's why I bet more on changing the environment, usually helps better. And this is what, so I'll try to convince him to maybe change his routines, and if you could go a little bit earlier when the medication was actually working. But I was not successful with that strategy. Then obviously teaching the person, there are strategies that we teach people to get out of the chair. And I'm sure you all here have heard this is a very common teaching point that we create all sorts of things like nose over toes, putting the feet back. I particularly like to remind people that it all starts with putting your feet back. Without that, all the rest is not going to work. So what we do is break down the activity into certain components. And this is all done, this is supposed to be automatic, but unfortunately because of Parkinson's disease, that automaticity has been lost. And so now, but if you do think about these components, putting the feet back, pushing yourself forward, bringing the body forward and coming up, that this will work. The truth is, it doesn't work in every situation. Sometimes we complicate too much when we break it down. When we think about personalized care, it's a question of trying it out and then seeing if it works. This one was very personalized to this gentleman, which is, if you notice, he would get up with his heels together. So they're kissing, right? I usually say they're not supposed to be friends, they are enemies. In order to be able to ergonomically come up with less effort, your feet have to be apart, right? At least shoulder width. And so what we did is create the red line. I managed to convince him with the red line this time, which is to remind him before he gets up to separate his feet. And this is how we tackle the problem, and it wasn't an issue anymore. If I can solve this issue with one red line, that's great, because I have to jump onto other problems and I want to help the gentleman with. And this also goes in line with, if I can use changes in the environment to solve one problem, since usually there's a list of problems that we are tackling, at least as a physiotherapist, I usually start off, tell me your 5 main problems and let's see what we can do about each one of them. If the person says, I get difficulty getting out of the couch, and I say, can I convince you to put to increase the height? So just put another pillow on top of it. And that didn't mess with the aesthetics of the living room, so I managed to convince him on that. And that's great. Okay, so the problem solved. Let's go to the next problem, right? It's a negotiation that we have to have, and we have to be creative in finding solutions at all levels. Let's think about our guide here. If another example about how about falls getting out of bed? That's connected to that rigidity of the trunk that I was saying. So this was one of the complaints. The gentleman would try to get up, and with the effort that he would make, he would fall. And how did I decide to solve that? It's very difficult to help people with mobility in bed. And we can train this in the clinic. We can train it over and over and over. But the truth is, at night, people are tired. People have less medication. So it doesn't compare to when you're doing it in the clinic. And that's why it's extremely difficult for us to have results. That doesn't mean you shouldn't train it. Obviously, the more you train it, the more you will know which movements you're looking for. But the truth is, making changes in the environment solves the problem more quickly. So the change that we did is just this grabbing onto this, pole, I think. So I'm looking for the word in English. This grab pole, I think.
It's a bar. Is it grab
A
bar?
bar. Okay, yes, okay. So, and it's very simple because you don't have to make holes or anything. You just put it underneath the mattress, and it's life-changing. Every single person that I recommend to use this really, really appreciates it and says it really changed their life. It reduces the care partner having to wake up in the night to help as well to get out of bed. So another tip that in case you consider it, it's very interesting. Another strategy is to obviously train in different times. This is actually my strategy was to help challenge the gentleman to teach me how I should be getting in bed. And so he's very enthusiastic. You might not understand Portuguese, but he's very enthusiastic, telling me, you have to place your hand by the pillow. This is things I had taught him before. And I just wanted to make sure if the knowledge had stayed. And then you turn to the wall. Yes, I'll wake up like this. And now, so by really using different type of methods in terms of teaching how we can probably consolidate and help people learn better. And I think that's also important. So he's worked it out. He says, I'm going to use my leg here. I'm going to push, and then I'm going to do. And I say, but you know, if you had your little thing here, it would make this much easier. Okay. Let's give you another example. So the importance, the whole message of the whole talk is like, if we identify well what is causing my falls, I can get to solutions. And here's another example. The person complains about falling out of bed due to enacting the dreams. So that means that sometimes people might be moving during their sleep. It is a severe problem because it has a direct impact in safety of the care partners and the person that's sleeping with them. And so that means, okay, during the night, this is happening. Is it a treatable problem? Yes, there's pharmacological interventions, and there's also tricks and strategies that we developed, like maybe placing the bed against the wall, maybe having some other grab bars. The one I think that I found more interesting was the person actually sleeping in a sleeping bag. And so by sleeping in a sleeping bag, even if the person is having movements, they won't hit the other person. So I find that one interesting. But you can consider several things, and the professionals exist for that. They can help you get to the solution, right? Placing a mattress on the floor seems like a good solution as well, in case the person falls from the bed when you have very vivid dreams. The only problem with that is if the mattress is too soft when you get out of it, then there's a certain risk of walking on an unsafe surface. So maybe a type of floor. I know in the States you usually have lots of floors with carpets, which is awesome. We don't. We have hard floors. So I think that might already be a good solution. Let me think. Pillows, okay, that one's obvious. And yeah, and a sleeping bag. But I will say that there are guidelines, medical guidelines, that have pharmacological interventions for this problem, which is a specific changes in sleep disorder that you should talk with your doctor, obviously. And this was just to tell you that there is solutions. So if you are dealing with this, make sure you work with your doctor for this. Okay, everyone hanging in there? Let me see the time. See if you get tired of my voice. Okay, all good. How about we go into something that maybe we talk more often? And that is changes in posture, changes in balance, having smaller size footsteps, and so the most typical changes that we have in gait and balance. And this is just an example of there's a lot of research that's been done for balance, particularly in gait and falls. Physiotherapy is commonly the profession that dedicates more to this, but not exclusively. And what we do, we try to understand what is happening. And this, what you can see here is we have our center of gravity. It's like, I don't want to go into a lot of details, but just so that you understand that when we are in the standing position, we are not completely still. And what happens when we have Parkinson, the more there is more movement than in someone that doesn't have Parkinson. And that's represented by these two images that you have here. And this is probably happening because of this specific problem, or I'd say characteristic. I wonder if I can challenge all of you to look down on your feet and see where they are. See if your heels are very close to each other. This is something that happens very commonly, and you will not perceive it. Remember, your brain is taking decisions that you normally wouldn't, but because there's lots of compensations happening due to the disease, then we have there's patterns and movement patterns that are happening. And this is a very common one. This is actually a picture taken in one of the conferences, and you could actually identify the people with Parkinson just by the way they place their feet. Can we do something about this? We can raise awareness for it, right? I'm transmitting. If you haven't been aware of this, if you do keep your feet comfortably apart, you will feel more safe. You will feel more balanced. So one of the ways, like people will say, I'm talking with someone and I get really tired and I start walking slightly back. That means we're losing our balance in that moment. And if you are able to remember this strategy, it's according to what people tell me, it really is life-changing as well. So hope you take that one too, is keep your feet apart and you will be able to have a better sensation for your balance. And I'll show you particularly even in the walking. So that is when you stop and talking with someone or you're doing something in the standing position, just being aware of separating the feet will be very, very helpful. Even for anything you're doing with your hands, right? If you are off balance or talking even, if you might not perceive it, but if your brain is perceiving you're not balanced, that means it will interfere with the way you are able to grab onto things, the way that you are able to communicate, and the way that you are able to think. So if we can reduce that by just opening our legs, isn't that wonderful? Isn't it a simple strategy? Yes? Okay. And you could see now what's more difficult to get is strategies for the walking, because you can see here it's like the gentleman, there's a tendency for the feet to be very close. And even if he takes big, gigantic steps, right? You hear this from therapy all the time. Take big steps. But the feet are together. It's like the person's walking on a line, right? So what we should be focusing on is how can I keep those a wide base? How can I keep the heels from being together and walking in a line? And that will require training, obviously, right? When it's posture based, when I'm stopping to talk with someone, this is an example of I tend to play with permission, obviously. That's why I'm showing you these videos, to to take these pictures so that I can help the people that I'm with to see the problem, right? So raise awareness for them so that if they can see this, oh my goodness, I didn't know I was that much. So we all know that in Parkinson, there's one side more affected than the other, right? The asymmetry is part of the diagnosis, which means there's one side where you'll feel more comfortable. There's always one leg where you'll be more on top of that leg. That means you're running away from the other one. And the picture that I'm showing you is when the situation is taken to extreme, right? So the gentleman, when he's interacting with anyone else, it's almost like the left side doesn't even exist. If he's going to take a step next, you can see the difficulty that it will be for the brain to take a step after when he's in this position. When we think about freezing of gait, which is the feet being glued to the floor and those changes, they are so complex. There are congresses of weeks, of a whole week, just to deal with this problem. So you can imagine how complex the phenomenon is. There's lots of things that can be identified at causes. But for sure that all these compensations are definitely contributing to the problem. If we can teach people right from the diagnosis that they should focus on stimulating the most affected side to make sure that we are doing walking and reinforcing that side, these problems will probably be less. Here's another example. I really want to reinforce this one because you can get access to help for this, right? So it's there's a lot of exercise opportunities for people to be able to really focus on how can I improve this asymmetry. This gentleman, usually I notice when people go on holidays and when they come back, the asymmetry is greater. On Mondays, the asymmetry is greater. Just the weekend, because usually on Sunday we spend more time sitting down. And these are all people that you see that are doing therapy 2 or 3 times a week, ongoing. We battle to keep it. We use different types of strategies, and this is also like if you have an occupational therapy or physiotherapist that can go to your home and help you identify places where you might be falling and how you can apply these visual cues that I think they work so wonderfully, because once you go in the kitchen, you don't really have to think about it. You see the lines and you know exactly where to put your foot. It's like going up the stairs. Like people usually refer, they don't have so much difficulty going up the stairs versus walking. It's that. It's your brain knows exactly where the feet goes. A more challenging one is, of course, turning. That would be a talk on its own, just trying to understand how we can improve the turning. I usually teach people, if you go into the right, then it's your right foot that has to move first. And sometimes it's a detail that people don't think about. And so they are trying to go to the right, but they're moving their left foot first. And so that brings on the struggles. Again, the idea of the talk was to just give you a general guide on how you can maybe look for further help on how to improve the falls. And as I come to an end, I just want to also think about, okay, how can I learn how to fall? Now, in an ideal world, we all would have something like this. Then we could just walk around free. In case there's a fall, poof, we have an airbag that pops up, right? It seems like an excellent idea. The only problem is it's not reusable. And so, and it costs a lot. There's a lot of money. I don't know if it was like 800 euros or something, which is what a wonderful idea, what a wonderful creation, but it's totally inaccessible to most people. And in Parkinson, because as you saw in the first slide, if the frequent falls, then this is not possible. So we have to deal with what we have, right? And I want to reinforce that the way we help someone get up from the floor is also important. Because there's frequent falling, that's important to teach how the family knows how to do it. Controlling the panic. If you learn this stuff, you can control more the panic and the anxiety, making sure the person's not hurt. I don't want to state the obvious, but it's just knowing that protecting yourself, if you are the one that's helping, is very important as well. Just getting a chair. Most of the time, the person can actually do it by themselves. So it's important to train this beforehand, and then just see what the person can do. But sometimes the family is such in a panic that they just want to, take the person. They want to solve the problem immediately, so they're just pushing and pushing, and they might hurt themselves. So it's worth working with someone so they can train that with you if you are the person living with Parkinson. This gentleman is 89 years old. I didn't say in the beginning. He's a very stubborn person. I love him to death. He's very intellectual. He he will every strategy that I get for him, he will question it over and over. But this one it's interesting because it's like him learning how to get off the floor, and you can see that lots of things will be the problem here. It will be the fatigue, it will be the rigidity, it will be the weight, the lack of strength. It's someone that spends the whole day on the couch. So I have lots of factors that are contributing to, but he's still able to more or less
I'm gonna stop listening because I'm getting
find his
depressed.
way, right? And this is stuff that you can train with therapists. Hold on to something. Make sure you do it calmly. It is important because people will try to get up quickly and then they might fall again. Yeah. What other things that I'm just going to share with you, that this gentleman, he decided to train his wife for when he falls. And so he actually, this is horrible. Every time I have to tell the story, I'm perplexed by when I said he was an intelligent man. This is horrible and intelligent. He actually pretended to fall often, so that, and he would call his wife as if he would have a real fall and have her deal with the situation of getting you out of the floor. And he would tell me, I have to train her, and he's an adult. I must say, I wonder if your wife ever finds out. I don't know what's going to happen, right? But yeah, so people create their self tragedies. I thought it was quite extreme because I think it's quite cruel. If we needed that much, probably not. He also started using an iWatch, and which actually is, I say, he was worried because once he fell, he had his phone in his pocket, but it flew away. So he thought, no, I need something that sticks with me. So I think it's also using new technology could be a nice message. Even though his age might have been a limit to technology, he actually figured it out. And when he fell, he could call his wife. So it's sometimes it's really details that changed a lot. And there's all sorts of detecting devices at this moment that will help alert the families as well in different types of devices. My last hope for the frustration of trying to help people not fall has been really taking a little bit more extreme, starting. This is someone that was diagnosed very young, so obviously it's young onset that we can try these things. But not only, I will try it with any age. It's just really having the right environments where we can train people is also important. So we've been doing a lot of research in trampolines, in really challenging balance. We know it's one of the main factors. If it's part of the disease, and so we want to really help people stay well. We'll be focusing on extreme balance and we hope that we can bring more solutions. And to just finish with some key messages, I would like to alert everyone that there is a risk of thinking that falling is normal, but there is a lot that we can do, right? It has a severe impact on families, and so that really has to be respected. There's multiple factors that you could see that horrible slide that I will call it, but the truth is we do have ways to manage them. We just need to get to the right cause first. Okay, so I hope that was useful